Those who came along to our very first seminar about 3 years ago, if they recall, we had a full house, and so we locked the doors about 15 minutes before. And then eventually the doctors and everyone else arrived at Mexican time, but everyone else came nice and early. Anyway, thank you for coming. As you can see, this is like a warehouse here, but in about a month's time, we'll have an IV room, we'll have a MRI, we'll have a surgery room, all up here. Downstairs, we have 7 procedure rooms. We have 2 rooms for physiotherapy, we have an IV room, and we have what you'll be able to see when you go down there. It won't be open until the end of this month. So any procedures we're doing, and we're doing quite a lot at the moment, we're doing it at our other location, which is up in San Jose on the 3rd floor. So I'd like to introduce you to Dr. Spiel. He's one of the authorities on exosomes and stem cells in the United States, and he's thrown down here just to give a presentation, and I think you'll find it very interesting. So, this is coming up, Dr. Douglas Spiel. Thank you.
Thank you very much. Thanks, Barry. So, first of all, I appreciate you all taking time out of your busy schedules to spend part of your day with me. I came to Exosomes relatively organically. So I'm a recovering radiologist. I spent about 20 years doing interventional pain. And about 3 years ago, I heard my partner, Duncan Ross, speak on exosomes, and lights went off in my head. And I realized that I was walking into something, probably the second time in my career, I thought medicine was changing before my eyes. And I remember when I was in my first year of med school, I don't know if you all remember Lance Armstrong and all the doping with erythropoietin and Epigen, but I had someone come into my class and they said, listen, if you guys all take $10,000 out of your pocket, and I was in a state med school and I looked at the kid next to me and that's kind of what it looked like. And he says, if you take $10,000 out of your pocket, you guys are all going to be millionaires in 2-3 years. He was right. Erythropoietin and Epigen climbed off the charts, and today it's mainstream. When I heard Duncan Ross speak, I had the same bells in my head, and I said, I don't know how many times in my career I'm going to have the ability to utilize something almost at step 0 and go forward with it and accommodate it into a lot of the different protocols that I did. So I'd actually flown back to New Jersey. My wife and family live in New Jersey. And I flew back down to Miami to spend a day with Duncan, and I bought some product from him, and I started utilizing it. And very much like all of you, I was a blender. So I was using stem cells from bone marrow and fat, and then I would mix in some of the exosomes, and I tried to get an idea of how much of this and how much of that I needed. And then I started delving into the science. So my purpose in meeting with you all here today is to introduce you to some of the reverse engineering that I went through in my own mind. So when I first came upon exosomes, I didn't really fully comprehend what they were and how they worked. And so I know that they worked, and then I would say, okay, how much does it need? And where do I use them? And how do I demonstrate their efficacy? So we're going to tie things together that you may not have ever heard in a singular talk. We're going to talk about the mechanism of action of stem cells and exosomes. We're going to show you examples of how I use them in my own practice. So for those of you who are practitioners, you should be able to leave this lecture and I'll give you some protocols that we use and how we do it. And if you're able to even put in an IV, you can start tomorrow using exosomes. Then we're going to talk about why they work. How do stem cells and exosomes work? And more importantly, why do I think that there's a unifying theory for aging and disease? We're going to look at oxidative stress. We're going to look in terms of inflammation. And we're going to look at what we call epigenetics. And if we put those things together, you'll come away from this saying, I kind of understand. And that's the biggest danger in medicine, right? When you think you understand everything. Because all big pharma likes to wrap their intellectual property around a single protein or a single antibody, right? There's the TNF-alpha inhibitors and the interleukin-1 receptor antagonists. And they try to make that into a drug. what you'll learn about placental MSC exosomes, and specifically those from Chimera, is why are they special and what's in the sauce. So, many of you who've started with stem cells, you see a lot of these terms. You see totipotential, pluripotential, multipotential. What does it all mean? I'm going to assume that you're all lay people. I may bore some of you with what I'm going to say, but I'm going to start from the very beginning. Because if I start the basic building blocks, you'll follow me. You'll hear what I'm saying, you'll see what I'm showing you, and internally it should start kind of potentiating further thoughts within you. So totipotential. You're 2 days old, you're a blastocyst. You're a little ball in mom's womb. Those cells need to turn into everything. They need to turn into placental tissue, and eyes, and ears, and livers, and everything else. You get a little further down the road, now they're pluripotential. They can no longer turn into everything like placental tissues, but they can still turn into muscle, and ligament, and nerve, and hair, and pretty much everything else. By the time you're born, mesenchymal stem cells are multipotential. They can turn into everything in that cell lineage. They can. Doesn't mean they all will. And then finally, the reason all of this stuff works, all of the whole idea of stem cells, we used to think if we gave you a stem cell, and I walk to this young man here, and we do a biopsy, and we take some of his bone marrow, and we take some of his fat, and we put it in along his nerve. For years we thought that those stem cells are going to become nerve. Now we realize that they don't engraft. And the reason they work, and this is like the biggest thing to wrap your head around, the reason they work is there are progenitor cells in every tissue niche of your body. That means in the central nervous system they're there. They're there in your liver, in your lungs. I'm going to show you even in the musculoskeletal system, even in your joints. There's prechondrocytes and preosteocytes and pretinocytes, and all of these cells that are willing to turn into those specific cells, but need a little push. So the resident progenitor cells are the reasons that both stem cells and exosomes work. For many of you, you've seen the ads, and many of you have dealt either with autologous cells, that's from you for you, or allogeneic cells from someone else for you. And what's the pluses and minuses, eh? When you look at autologous blood or autologous fat, that's you to you. 0 chance of rejection. However, there's an attrition rate. In your bone marrow, from the day you're born, 1 out of every 10,000 cells is a mesenchymal stem cell. By the time you're 20s, 1 in 100,000. 50s, 60s, 70s, 1.5 million. 80s, maybe 1 in a million. In your fat, there are more, but there's an attrition rate in fat, you lose about 10% a decade. The bigger problem is as you age, so too do your stem cells. They don't produce as many proteins, or as many protein factories known as messenger RNA. So younger is better. So everyone started shifting, well, younger is better. I like the idea of umbilical cord blood, right? Or Wharton's jelly. And there's some real benefits there. Some of those cells are exceedingly young. And they don't have MH2 markings, but they still have major histocompatibility number 1 markings, which means you will kick them out of your circulation. If you give them IV, 12 or 16 hours later, your cells will pull them out. But they do release little bubbles, little vesicles, exosomes. The other problem, and even a bigger problem now, is people don't fully understand this. But when you take Wharton's jelly, or you take stem cells, first of all, you got to keep them from, after you freeze them, you got to take out the DMSO. So if you have a sulfur allergy, and you've received the umbilical cord Wharton's jelly, you're going to react to the DMSO in that preparation if you don't wash it off. Secondly, even after you wash it off, does anyone believe that mesenchymal stem cells are the only cell in Wharton's jelly, or in bone marrow, or fat, or any of these things? No, of course not. So there's B cells, and B cells produce proteins, and specifically antibodies. So if I'm unlucky enough to get the Wharton's jelly, or the products from someone else who had type A blood and I have type B, I can truly get a graft versus host reaction. And that's why you see some of these untoward reactions in these patients. So as we move forward, I'm not going to stand here in front of you and tell you that bone marrow and fat and all these other allogeneic products don't have efficacy and they don't work. Absolutely they do. I want to introduce you to a safer choice and explain to you why it works. So these are the ways that generally people have been playing. By the way, amniotic fluid. I've seen a company now producing amniosomes. So if you take 250 cc's of amniotic fluid, you have roughly 40 mesenchymal stem cell colonies. So at 6 cc's, maybe you'll find one. But people are still promoting it as exosomes. Yes, there are exosomes in there, but they're mostly from fibroblasts and epithelial cells. As I said before, Arnold Kaplan, 20 years ago, called these mesenchymal stem cells because in a petri dish, you could take an MSC and you could drive it into bone or cartilage or muscle or nerve. In your bodies, they don't generally engraft and become those things. They secrete particles so that you turn on your progenitor cells. The hepatocytes, the prehepatocytes turn into liver tissue. Prealveolar cells turn into lung tissue. Even, believe it or not, they lied to us in med school, even in your central nervous system, there's areas of your brain and your spinal cord, the subgranular zone, the subventricular zone, the hypothalamus, where there are precursor cells that will turn into neurons, brain cells, and even the supportive cells known as glial cells. So then he wanted to reposition his terminology. Instead of MSC becoming mesenchymal stem cell, he wanted to recall them medicinal signaling cells. And that's essentially what they are. They're little pharmacies. So how does this work? So let's digress for a minute. These are studies that have been going on for about 150 years. So they started with a gentleman named Paul Burt. And what they did this experiment known as heterochromatic coupling. You take an old rat, you take a young rat, you skin them, you shave them, and you suture them together, and you let them run around for a couple of months. And then, for their troubles, you euthanize them. But physiologically, if you look at the old rat, it looks younger 3 months later. So what are they mixing? Well, they're mixing some kind of life fluids. They don't tell you a lot about the young rat, who's aged well out of proportion to the 3 months that he's been attached to his older friend. We'll get into that. So people on the West Coast of the USA immediately started making money based on this trend. So Wes Corey was a scientist at Stanford, started Alka-Hest, where you could get plasma, which is the fluid minus the blood. And then Ambrosia even opened up where they would sell you fluid for about $6,000 or $8,000. And they've shuttered their doors and recently reopened, selling another protein mix. So you have to realize there are very few stem cells in your peripheral circulation. What you have, because of the fact that stem cells, the little pink guys there, live on blood vessels, the blood vessels are the highways of your body. So paracrine secretions, things that come out of cells, if the cell is hugging the highway, it releases these secretions into the highway and they traffic everywhere. So stem cells are parasites. They live on these little blood vessels and capillaries, and in doing so, they secrete these little bubbles that get picked up by other cells. If I give you these little vesicles, and I give them to you IV, I can tell you within about 6 hours, they'll get picked up by your liver, phagocytic cells known as Kupffer cells. They'll get picked up by your lung, alveolar macrophages, and all of these phagocytic cells migrate to your spleen, so you'll find them there in high amounts within about 6 hours. Now, there are some artificial designations. If they come from the inside of the cell and they carry the membrane of the endosome, they're called an exosome, and they're about 40 to 100 nanometers. Really, really small. These things are on the size particles of viruses. If they come from the external plasma membrane and they're 100 to 200 nanometers, they're called microvesicles. Now, they contain many of the proteins in the walls of their parents, and it's very important that you realize this, because you'll read a lot about microvesicles and exosomes. Good parents have good kids, good daughters, right? Bad parents, cancer cells, bad kids. So while many different cells secrete exosomes and microvesicles, it's very important that you want to start with the best parents. And in our estimation, the best parents are placental stem cells for two reasons. If you remember nothing else, remember these two reasons, because this will explain why I use them everywhere. They're pro-growth and anti-inflammatory. There are other cells that are more anti-inflammatory. You can take a T regulator cell, which is exquisitely anti-inflammatory, but doesn't cause growth. And for all of you, I'm looking for the best thing together. So that's why we use those. They're combined vesicles containing proteins, messenger RNA, which are little protein factories, and then they have some microRNA and this plasma coating, so they're tolerant of traveling through your circulation. So some of the key advantages. Why is an exosome great? And by the way, stem cells work by the secretion of exosomes and microvesicles. So even if you take your own stem cells or somebody else's, this is the reason they're making changes. So they can travel everywhere, we talked about that. They can travel locally and distally. They can even cross the blood-brain barrier. And I'll show you that later, how they transcytose. They get through a layer of cells where they each pick them up and then hand them off like they're in a rugby tournament. They deliver micro and messenger RNA. MicroRNA changed what your own DNA makes, whereas messenger RNA are giving you your own little protein factories. They can home, meaning they're wickedly migratory toward these phagocytic cells like macrophages and dendritic cells. They're not perceived as foreign. They don't get caught up in the lung circulation. They do get picked up by the macrophages or phagocytic cells of the lungs. They don't turn into tumors. Why? There's no DNA. They're easy to administer, easy to dose, and they're very potent, and we'll talk to you about that. Now, some of the therapeutic effects, what do? Well, they can turn, phenotypically, they can change cells. So they can change T helper cells, which are very important for an inflammatory reaction, and make them a T regulator cell, which is an anti-inflammatory aspect. They can take type 1 macrophages, hyperinflammatory macrophages, and change their clothing so they look like M2 anti-inflammatory. They're pro-regenerative, they're immunomodulatory without being immunosuppressive. So it's not like giving you a dose of steroids. They're anti-inflammatory and certainly anti-fibrotic. So, some things you need to watch out for. Once we started talking about 2-3 years ago about exosomes, every company got the bright idea, well, I'm going to create one. Because everyone wanted to take money off the table. And that's sad because there's been a number of untoward reactions. Remember this, if I take a completely sterile MSC population of only stem cells, and I grow just the stem cells and expand them, and then filter off the culture medium, which is their food, and take the cells off, I'm left with those cells' progeny, the exosomes, from those cells. If I take bone marrow, or I take fat, or I even soak a placenta, by the way, just so you realize, even in a placenta, like I told you about bone marrow, 1 out of every 10,000 cells when you're born is an MSC. If I soak any one of those things, and even if I screen everything below 200, 250 nanometers, they're all vesicles, right? They're all from stem cells? No. Maybe 1 out of every 10,000 is from a stem cell. And remember that antibodies are much smaller than vesicles, so that there's 50 antibodies for every exosome. If you had B cells, which were in that placenta, or in that bone marrow, or in that fat, you're going to catch those too. It's a big difference to get a sterile growth factor panel and exosomes and microvesicles from stem cells than it is to just soak a tissue and assume that all of the exosomes and microvesicles you're getting are from stem cells. So the number of exosomes, everyone wants to count things. Well, remember, there's a 4/3 pi r squared phenomenon, so that if you're looking for the size of a particle, and something's 70 and something's 140 nanometers, so it's pi r cubed, so that 2, 4, 8. The one that's 140 nanometers contains 8 times as many products as the one that's 70 nanometers. You'd have to look at that. You'd have to look at where the exosomes come from, what percentage of the exosomes come from stem cells, and then you have to decide, is it pure? Are they truly screening off the culture media, or is there suspended just in saline? So there's a lot of questions that I have with many of the other companies that are trying to produce exosomes and trying to sell these. So, I'm going to show you some panels. And here's a very important thing I kind of want to wrap your mind around. It's one thing to give you a protein. Proteins last for a relatively short time in your body because you have proteinases. And when we talk about exosomes making changes in your bodies, I'm going to tell you that there's kind of a three-step approach. In the first hours and days, you'll see changes from proteins. Then, from weeks to months, you may see changes due to the protein factories, the messenger RNA. And then as we go out 4, 5, 6 months, and I've seen this with my own eyes for the last 3 years, I see changes in people that are not accountable by the proteins and the messenger RNA because they are way gone. We see late changes that I think are due to epigenetics, changing the profile of your cells in general, and we'll talk about that later. When we look at some of the exosomes and we look at some of the growth factor panels, I'm going to show you two separate things. I'm going to show you proteins, and then I'm going to show you assays for messenger RNA. Some of the important proteins, GDF15, by the way, has gotten a lot of play recently. For any of you who are trying to live longer with longevity, people are taking metformin now, right? Metformin makes you live longer. Metformin increases GDF15. GDF15, recent articles, some of them out just last week, have shown that GDF15 is one of the reasons to prevent cell death in your pancreas for type 1 diabetics. So we'll go through a number of reasons why I use these things for diabetes, but as we reverse engineer and scientists learn new things, it's not enough just to read the literature on exosomes. You've got to read all types of different science and start grabbing things and putting them together. GDF11 has been termed the fountain of youth gene, the gene that's necessary for you to live longer, and actually tried to give animals GDF11 protein, but they failed because the protein lasts for a few minutes. But suppose I show you that GDF11, the messenger RNA, is in the exosomes. There's stimulating factors. TGF-beta3 is extremely important because it causes a persistent and long-lived shift from a T helper cell, highly inflammatory, to a T regulator cell. VEGF to grow blood vessels. Now, I said before, when you look at big pharma, they're going to wrap all of their intellectual property around TNF-alpha, and these are your Remicades and Humiras. But in exosomes, from placental MSCs from Chimera, interleukin-1 receptor antagonist, interleukin-10, tissue inhibitor metalloproteinase, TNF-alpha receptor antagonist. These are all anti-inflammatory substrates in the one solution. There's glial-derived and BDNF, and there's even neurotrophin-3, which is really kind of interesting. This has got a lot of play also. People are trying to take peptides now, and I deal with a lot of spinal cord injuries and brain injuries. So everyone's interested in neurotrophin-3 because it causes increasing dendritic growth, where if you have a spinal cord injury, your motor neurons die and they withdraw, and neurotrophin-3 causes them to send their little branches back out to the motor units. That's kind of cool. These are separate profiles. These are actually messenger RNA. So these are specifically looking at the protein factories themselves. And if you'll notice here, here's GDF11, here's GDF15. IGF binding proteins, these are the things that cause IGF-1 to circulate better. So growth hormone in your brain produces IGF-1 in your liver, and IGF-1 is responsible for all the different growths with muscle and nerve and everything else, and I'll show you that in a separate slide. So when we talk to you later, this is really cool. And originally when we assayed these went kind of unnoticed. There's a couple of different things that will help you influence your cells. And as we get older, people have been trying to quantify aging. So how do we age less? And everybody likes the telomere play. Well, I don't know if you've read a couple of months ago, they saw an astronaut who had a twin brother. And he went up into space. And he came back down, and boy, his telomeres were a mile long. But in a week, Probably got 60 times the ionizing radiation in space that you get here on ground. So maybe the telomeres aren't the best way to look at it. But there's another way to look at your DNA via methylation and histones, and we'll talk about that. As you get older, your DNA starts coding for less and less RNA, and then you make less proteins. Perfect example. We're born, we're lactose tolerant. As we get older, we stop making lactase. So we can't have the milk and the ice cream unless you take the lactate. That's not always as much fun. So as you get older, you wrap up portions of your DNA, either with methyl groups or histones. You don't need to make a liver once you're born, right? You don't need to make new eyeballs. So progressively, as you get older, more stuff binds to your DNA. And there's ways that you can make it go south. There was a new study out this week that looked at, everybody drink milk? A little bit in your coffee? It's fine, my coffee. So I'm not a great milk drinker, and I know there's all kinds of other better choices. But calcium is certainly important. And we know if you just take calcium pills, it winds up in your vessels. So you're supposed to take calcium either in your milk or your orange juice or just a slower release dose. 2 and 3% milk drinkers increase their methylation age of their DNA by years. And you have less of those changes if you drink non-fat milk or 1% milk. Everyone don't go home and throw all your milk out. I'm just telling you that you can change things adversely or for the better. So one of the ways you do that, you decrease what's known as oxidative stress, so we'll get into that, and you decrease inflammation. Or you produce messenger RNA that code for enzymes that are histone acetyltransferases that unwrap your DNA directly. And that's what those enzymes do. So again, this is a nice chart. It talks about all the different things, and it compares exosomes on the left to amniotic fluid on the right. And for those of you who've heard me speak, frequently I like to add amniotic fluid to exosomes. Why? Because it's got a lot of TGF-beta1 if I want to grow cartilage in the knee. And if I want to mitigate pain, there's a lot of anti-inflammatory proteins that are higher in amniotic fluid. So when I go into joints, I'll add it in there and the pain response goes down very quickly. They've done studies actually comparing amniotic fluid with hyaluronic acid derivatives. Those are the injections, the motor oils that they put in your knee, Hyalgan and similar drugs. So what you'll notice is the exosomes are sometimes a little symbiotic with the amniotic fluid. So sometimes I'll use them together. I don't give the amniotic fluid IV. I only give it to joints and other areas. But some of the other things that we talked about, you'll see there in a slightly different representation. And again, this is similar, different representation. So when I look at possible ways that I can utilize exosomes, everything that I've done is up to about retrobulbar. So I don't do eyes, I don't do ears, and I'm not set up, although I'm a recovering radiologist, I don't do any angiography anymore, so I don't have a lab. Certainly in the US it would be very difficult to do that. I don't go into the bladder, I don't go directly into the kidneys. You can add, I don't do colonoscopy either. But everything on the left up through oral, I've done. So I do intradermals and peridurals and nebulized and intraarticular, into muscles and tendons and ligaments and discs, intranasally. I'll show you how to put it through the cribriform plate. Intrathecally, into cerebral spinal fluid, intraperitoneally. I do a lot of autoimmune disease, and that works really, really well. So I've been able to shut off inflammatory bowel disease for 4 or 5 months at a time. Intravenous, intrabursal, epidural, intraosseous, we'll show you that. And there are plays for oral. I've had some patients take it that way, although I generally don't prescribe it that way. So let's look at some of these, and let's look how it plays out. So this is a pretty good slide, because if you appreciate just in the joint, there are prechondrocytes, preosteocytes, pretenocytes. These are cells that are almost cartilage, almost bone, almost tendon. They need a little kick in the ass, or maybe some coffee in bed. So, this is an interesting way that I play now. For those docs in the room, how many docs in the room, or healthcare providers? So a good smattering here and there, eh? So, for those of you who get your MRI back, and you realize that it's not just the joint where you've lost some cartilage, But if you look, there's some inflammation in the bone, or there's bone bruises, right? You see them most frequently in the knees and the hips. What I started doing is not just putting these into the joint space, intra-articular, I started doing intraosseous. So that for people who have avascular necrosis, or you've got a significant inflammatory reaction in the bone, I treat the bone directly. And we'll talk about how to do those things together. Osteoporosis and osteopenia. This is a huge problem, right, for women after menopause, and even for guys. And as you get to know this and understand this a little bit more, yes, estrogen is responsible, and the loss of estrogen is responsible for the uncoupling, right? You have osteoblasts forming bone, and osteoclasts breaking bone down. You want more blasts. Unfortunately, as we get older, this kind of happens. So specifically, when you look at all these things, one of the key factors in causing more osteoclastic activation, bone breakdown, is T-cell inflammation or T-cell activation, or more specifically, an elevation in T helper cells. But if I give you IV exosomes, you dampen that, and you'll lay down more bone. Case in point, 65-year-old friend of mine, so tell me what's wrong with this equation. 65, neurologist, motorcycle. Either the 65 in the motorcycle or the neurologist in the motorcycle don't marry well. So my friend Shelley calls me, Doug, I'm in a lot of pain. I go, what happened? I broke 11 ribs, I got a spleen and a less. And he tells me everything on the left hip. And he goes, what should I do? I said, you need a boatload of exosomes. So he was out in California, we shipped him a boatload of exosomes. Normally, in IV administration, I give 15 billion. This guy, we gave 25 billion. Anyone ever break a rib? How long does that hurt for? Weeks. How about months? How about 11 broken ribs? How about no rib pain in 2 weeks? That's crazy, huh? But even more astounding to me, this is 4 weeks between these two radiographs. I know him because I was seeing him walk around after this. Can anyone see the fracture line 4 weeks later? No. Really, really remarkable. Autoimmune disease. And when I talk about autoimmune disease, just so you know, I've been able to turn off Hashimoto's, and we've turned down RA, and certainly it is wonderful for inflammatory bowel disease, Crohn's and ulcerative colitis. But pictures, right? Everybody wants to see pictures. Sometimes today I'll show you lab work, and other times I'll show you pictures. So who gets autoimmune disease? Who gets autoimmune disease? Girls. So many more times, right? 80% of autoimmune disease is girls. And why? There's an old hypothesis. Back when we were all cavemen and we had our lives in the dens, they would get pregnant, they would give birth, they would get pregnant again. When you're pregnant, you're at an extremely high level of anti-inflammation. Now, if you gave birth and you stayed at that level of anti-inflammation, bacteria and illnesses would overrun you and you'd die. So this goes on their whole lifetime. Now women have 2 kids, sometimes 3, sometimes none. It's a lot of unopposed inflammation, and that's one of the theories behind it. So vitiligo is an interesting representation. You have to know, when you have vitiligo, you have autoimmunity, or you have essentially antibodies attacking in the epidermal, dermal, and subdermal layers. You're killing your melanocytes. Now, can they hide anywhere? They can, and they tend to hide in the hair bulbs. So if you've got a lot of vitiligo on your hands, the palms, your feet, mucous membranes, not going to work. On the other hand, if you have areas around hair, you can dampen the immune system, rescue the melanocytes from the hair, and repigment certain areas. So let's look at an example. And there's perifollicular repigmentation. These are some of the ways that it works. So here's a kid. So top picture, the bottom left picture is 3 weeks, 4 weeks. And what I want you to look at specifically is look here, and look at these satellite areas here, between the hair here and the hair here. Look at how nicely they fill in. Even out here, starts filling in, and down here. And if you go out for a second treatment, you see even more pigmentation. This is an example of how you're changing the inflammatory milieu just from IV. So inflammatory bowel disease affects more than 1% of the US population, so 3 million people. This is a big player. And for me, it's very hard in the US to get patients to come in that want me to do the treatments. We do an intraperitoneal treatment, which is essentially through the wall of the abdomen under ultrasound. The problem that I have is that in the US, everybody's covered. So the big pharma drugs that cost 60, 70 grand a year are paid through their insurance. I get a tremendous amount of brain injuries and spinal cord injuries, and obviously the joints and other things, because with the brains and spinal cords, hey, there's no other choice. There's no sovereign treatment option. But with inflammatory bowel disease, unfortunately, there is. The problems are myriad, and if you look at the Canadian studies, Canada has failed magnificently in decreasing hospitalizations and surgeries just by treating these patients with TNF-alpha inhibitors. And one of the bigger problems, sometimes I don't ask for what walks into my talks. I just treat patients and things present themselves to me. So I keep getting calls, and this is weekly. I field calls from docs all over the country and all over the world. And they ask me, why do you have to stop the TNF-alpha inhibitors, the Remicades and the Humiras? And I tell them, because they're immunosuppressive. So this is a kid with inflammatory bowel disease on an immunosuppressive drug who comes to me for a separate problem. Just on a TNF-alpha inhibitor, he develops an epidural abscess. So for those of you who aren't docs, this is your spinal cord. This is an abscess in your spinal canal, squeezing your spinal cord. So just treating his inflammatory bowel disease, this kid now has an upper thoracic spinal cord injury. So when I tell doctors to stop these drugs for 2 half-lives or so, this is the reason. You have to be wary of the side effects of everything that you utilize. So interesting, a lot of what we learn as physicians, we learn translationally. That means we look at animal studies and we try to confer some of that understanding to people. And when they looked at murine models of mice, they realized that the intraperitoneal injection did better than the IV or the perirectal injections. And basically all you're doing here is the superficial muscles, deep muscles, we put a needle in to the space over the bowel itself. And then, why do we put it there? Because for those docs who are in the audience, 70% of your lymphoid tissue is in your gut. And by the way, even with the little studies they've done with Cooper's-zone models in mice with MS, they've treated the MS in here because, by the way, where are all the neurotransmitters made? A lot of your neurotransmitters here are made in your gut too. So the gut is really, really important. And I know I get in front of people and I try to stay on point, and then I just tend to wander. It's my nature. But when I talk about exosomes, I don't mean to say that you should only use exosomes in a vacuum. I believe in hyperbaric oxygen, and for brain and transcranial magnetic stim, and focused ultrasound, and I do focused ultrasound in the joint. But very importantly for all of you, your bowel is key. And pre and probiotics have a huge position in your treatment algorithms for yourself and for your patients. The reason being is, people who have a breakdown in their bowel, the bacteria, and specifically bacteria that make flagellin, get through the brush border of the bowel and into your system, and you get a inflammatory reaction. We call it postprandial endotoxemia, where lipopolysaccharides comes in through the gut wall into your blood vessels. In fact, they've even looked at kids with autism, and they've done fecal transplantation. Seems crazy, right? So they take stool from not children with autism, they put it into kids with autism, and the kids turn around. The vast majority after the fecal transplant no longer have autism, because you're diminishing inflammation, and there's a lot of studies that suggest that autism is linked to inflammation. So again, this is part, you'll start thinking as I do about the whole organism. So there's a gut-brain axis, right? They looked at Belgium studies years ago, and for most of you are not old enough, but maybe 40, 50 years ago, they used to do vagotomies, where they would cut your vagus nerve. Those patients in Belgium that had vagotomies had a 50% decreased risk of coming down with Parkinson's. And there's a huge tie-in, right? The vagus nerve is the biggest nerve from the gut going right up to the brain. So the gut is intimately associated with the brain and your systemic circulation. So intraperitoneal injections make more and more sense to me. So this is, I started doing them a little over a year ago. I had this one patient that came in. His pain was 8 or 10 out of 10 every day. He was having 20 bowel movements a day. I gave him IV and I gave him perirectal exosomes. His pain score went down to a 5 and he decreased the amount of bowel movements. Within a day of going intraperitoneal, and for 4 months after, and this is normal that I see now, pain scores of 1 or 2. Big, big difference after one injection. This is an example. We're not going to take you through that. It's an instructive video on intraperitoneal. Docs that want to learn it, you can pull me aside later. Allergies. I was asthmatic for years. I've been taking exosomes pretty religiously for the last maybe 15 months. I no longer use an inhaler. I had a really bad upper respiratory infection last month. I still didn't use the inhaler. So when you look at asthma and skin diseases, a lot of the pathophysiology is related to dendritic cell presentations to T cells, upregulation of T helper cells, mast cell degranulation. I've started treating people with mast cell disease. And I'll show you the picture. And obviously there's been translational studies utilizing human placental MSCs, that sounds like Chimera, and showing that it decreases inflammatory mediators, shifts your microglia and your macrophages to non-inflammatory milieus, inhibits fibrosis, decrease extracellular matrix deposition, right? So that's going to clear up your lungs. And if you look at the picture here, you get to see all the different things that these exosomes are blocking. So very importantly, you're blocking the T helper cells. You're decreasing the B cells so that the IgEs aren't getting released and they're not causing mast cell degranulation, so you don't have the eosinophilic filling problems. You're increasing IL-10 and Treg cells, so you're changing the milieu of your body. And again, same type of stuff has been seen on studies for allergic skin diseases as well as conjunctivitis and rhinitis. Lyme disease. We used to think that all Lyme disease was a chronic infection. And now the CDC in the US no longer believes in chronic Lyme. Right? Although, you can test these patients and you'll see other co-infections, you'll see ehrlichiosis and babesiosis and Bartonella. Invariably, you can't pick up the spirochete anymore and they test negative for Lyme. So why do these people have so many damn joint pains? Well, one of the problems is when you look at the Borrelia and they release the Lyme, they release what's called peptidoglycan from their cell walls. And there is a lack of the machinery to pick the peptidoglycan to repurpose it back into the spirochetes. So when the spirochete infection dies, the peptidoglycan that was part of the cell of these organisms remains. And just shooting peptidoglycan into the knee of a mouse will induce an inflammatory reaction within 24 hours. So again, what we think now is that most of this is certainly due to the inflammatory reaction. So derm, just a picture showing you rosacea, just some local injection going away in 2 days. Again, another picture, I think this is out of Japan, just showing you, and the first time I realized that, hey, this works for IgE and mast cells, and started treating mast cell disease based on that. Infertility. So let's digress for a minute. That's another spielism, I'm sorry, I like to leave the mainstream for a minute. There's something very interesting about oocytes and spermatocytes. Very few places in your body is there the same level of mitochondrial DNA as there is nuclear DNA. And one of the places that that's true is in the oocytes. And those are the precursors for eggs. Because mitochondria, which are known as the powerhouses of the cell, are very, very, very important for replication. One of the reasons that we become infertile is due to the fact that we have mitochondrial demise. And we'll talk about the forms of oxidative stress as we go along today. But mitochondrial death and abnormalities in the mitochondria are intrinsically causative in causing problems with infertility. And I can tell you certainly about the young female doctor who came to me at one of my lectures in Florida about 3 or 4 months ago. And she told me about one of her patients who had a torsed ovary. And she had one ovary left, and she was mid-30s and badly wanted to have children. And she came in with lower pelvic pain on one side, and the doctor did the ultrasound, and there was no blood flow around the ovary. And she says to her, listen, we've got to take you to surgery. We're going to unwrap your ovary from its pedicle, tack it down, and we'll look. But if it doesn't regain blood flow, it's got to come out. She goes, Doc, do whatever you have, save that ovary, I want to have a child. And against her better judgment, she agreed that after the surgery, she would leave it in, and she would give the young lady exosomes. She gets in the OR, and the ovary looks purple, necrotic, and dying. She untwists it, sutures it down. So a torsion is where the ovary kind of twists on its own blood supply. So she untwists it and then tacks it down to the back line fascia. And she watches it for 20 minutes intraoperatively, and it doesn't pink up. So against her best judgment, surgeons are told dead tissue comes out, right? She closes her, and post-op looks at the ultrasound, dead. But she gives her 15 billion MSC exosomes from Camaro. 6 weeks later, she comes back, great blood flow in the ovary, and she came back after that pregnant. But I'm going to show you some more pictures because these are really good. So let's look at an animal study, and then we'll show you how that bears out to human stuff. So this is an unusual procedure. This is an autograft. An autograft is not taking something from that gentleman and putting it on me, but taking something from me and putting it elsewhere on my body. So it's autografting. And what happens when you take the ovaries out and put them elsewhere, there's an ischemia-reperfusion injury. An ischemia and reperfusion, you lack blood flow, you put it down there, you get the blood flow back, but that causes a lot of what's called oxidative stress and secondary inflammation, and that's deadly to the ovaries. So what they do, so I looked at the animals, and I'm going to come down here so I can see these a little bit better. So what they did, they took a control, and then the autograft, and this is the autograft with stem cells. And you'll notice that superoxide dismutase, hey, that's really good. That's an anti-inflammatory agent or an antioxidative stress. It picks up some of the oxidative stress stuff. That gets better. And then there's the total antioxidant capacity. That gets better. Goes from 0.71 to 0.81. Methylaldehyde, that is not good. That's an oxidative marker. So you want it to go down, and it does. Interleukin 10 is anti-inflammatory. You want it to go up, and it does. TNF-alpha, bad. Interleukin 6, bad. And those both go down. By the way, superoxide dismutase is not just important for these inflammatory reactions, but I don't know if you realize, ALS, Lou Gehrig's disease, there's a sporadic form, which is about 90-95%, and there's a familial form. And the familial form doesn't produce very much superoxide dismutase. So it leaves you in a wicked condition of oxidative stress. And the same is true, obviously, the follicles grow better with the stem cells, the volumes and the output of the follicles, the hormone levels, go up significantly after you add the stem cells. And there's other studies that makes it sound like it works for men. If it works in animals, and there's improved folliculogenesis in mice, should we try it on people? I say yes. So this is not going to come into most of your clinics. This patient chronicled his sperm counts for about a year before he saw me. So he literally had a book, and as you flip through the book, I was careful not to see if the pages were sticky, but as I looked through the book, he had rigorously entertained all the problems he had despite hormonal therapies, and he showed me month by month that he had 0 sperm count. So if you look here, I think it's January, and it goes April, May, and all the sperm counts are 0. And then June and July, still 0. I injected him 6/26/18, but what was amazing, about 9 weeks later, his sperm count was 90 million. For those of you who need to know what's the baseline. In order to get someone pregnant, it's about 20 to 25 million, and he stayed above that threshold for about 4 months. Erectile dysfunction, there's a lot of studies that have been done. I do a lot of acoustic wave therapy, and certainly we use this for erectile dysfunction as well. Stem cells certainly help, and they decrease penile fibrosis. They certainly help also in decreasing death or apoptosis of smooth muscle cells, as well as recapitulating a normal cavernous nerve. We used to think once the cavernous nerve died, you were out of luck. So when you look at erectile dysfunction, there's a couple of different things that happen synchronously. As we get older, the pipes get smaller, but we also produce less nitric oxide. So nitric oxide is important because if you take Viagra, Levitra, Cialis, if you're not producing any nitric oxide, then those drugs don't work. And what produces nitric oxide are blood vessels and nerves. So what they did, they looked at this sham group of rats, and they took a sham group, then they killed the cavernous nerve, and they added MSCs and they added MSC exosomes. And the group of the MSC exosomes did really, really well. And it's important to realize, there's arterial insufficiency, not enough arteries, and there's venous insufficiency, right? And then there's neuro insufficiency, or not enough nerves. And people used to tell me, well, the venous insufficiency it's not going to work for, because you're just going to build more vessels. Well, they really don't understand the physiology of the biomechanics. What happens is, as the smooth muscle cells die, the veins take up a bigger area of the corpus cavernosum. If the smooth muscle cells hypertrophy again, you press out the nerves. So it works as well for venous problems as it does for arterial and nerve problems. Disc injuries, I've done a lot of these. It's pretty remarkable. Some of this is this for about a year and a half, about 3 or 4 weeks after I look at resorb in the disc. And I've seen this over and over again. MSC exosomes certainly work very, very well. They share amongst themselves. They'll go to the cells, and they'll probably turn up some of the cells, and they'll probably cause some transmigration of cells coming from the bone marrow into the disc. When I first saw this picture, I thought I gave this kid, he's actually a professional basketball player, and osteomyelitis. I said, wow, his vertebral bodies are lighting up. But I looked at his blood cells, I looked at his white cells, and inflammatory markers, and they were dead zero. So this is just a inflammatory reaction that's really regeneration rather than true inflammation. Okay, these next 5 slides are really important. Although these 5 slides are talking about disc disease, intervertebral disc degeneration, this, in a nutshell, is kind of why exosomes work for the rest of your body as well. So we'll talk about low back pain, and that is obviously involved with 630 million people globally, right? If you've ever had a day where you've sat in your chair and your back's hurt, you know what I'm talking about. What happens when you look at the discs of your back, 2 major portions. There's an annular region, which is hydrophobic, not a lot of water in it, and a nuclear region that's hydrophilic, a lot of water in it. Well, the nucleus, as you get older, dries out, and you get inflammation in there, and it loses space, and the annular fibers kind of become redundant on each other. And there's cell death, there's matrix degradation, there's inflammation, and one of the biggest inflammatory cytokines on the internal surface of the disc is interleukin-1, which is highly inflammatory. When you get an inflammatory picture of the disc, it kills the metalloproteinases, and it digests the matrix, and things go south. It's been said, by the way, that the nucleus of the discs is where stem cells go to die, because it's an anoxic area, it's an inflammatory, it's an acidic area, nothing survives well there. And then these substances, these enzymes that are produced are proteolytic, and they digest the disc from the inside out. Now, prior research has demonstrated that inflammatory discs and degenerated discs have what's called inflammation, we just talked about, and oxidative stress, meaning that the stress kills the mitochondria within the cells. So they do a couple of things. They look at the IV intraventricular discs and they puncture them with an 18-gauge needle, and then some of the animals get a little bit of exosomes. Then this is really cool. We're going to come to this later. I just want you to look at this little area here, NLRP3. That is called an inflammasome. And the reason that inflammasome is so important, you're going to learn a little bit later in about 5 minutes when I remind you about the inflammasome that's getting blocked in the disc with the addition of exosomes. But let's go on. So human normal degenerated nuclear samples were looked at, and there are more inflammatory cytokines in the degenerated samples. There's more oxidative stress in those. And if you add the exosomes, you could decrease the amount of stress and cell death, and you could decrease the inflammation. So far, so good. NLRP3 is an inflammasome, which is blocked by exosomes. There's a reason I'm telling you that. So what they looked at when they added the exosomes, they looked at the inflammation and degradation, and they showed that the exosomes didn't just stop inflammation, but they stopped some of the mitochondrial death secondary to the oxidative stress, and we'll talk about that more. Here's what blew me away when I read this paper. When they looked at MSC exosomes, they realized that 11% of the proteins were mitochondrial proteins. If you believe that you die due to mitochondrial oxidative stress and inflammation, how nice it would be to take a vitamin that regenerated your mitochondria. When you looked at the gene ontogeny profile, not only were these proteins part of the mitochondria, but they lined up to the inner membrane, the membrane, the envelope, the matrix, the inner membrane space, outer membrane, and the nucleus. It lined up to all the important components of the mitochondria, which suggested to both me and the people that wrote the article that exosomes can rejuvenate your mitochondria. So we'll get back to that and show you performance optimization. When I first realized that patients were getting stronger, and yes, they get stronger. I have baseball players where their exit velocity have gone from 95 to 110. I've got athletes like this man who's 49 years old. He actually won the World Games last year at 220 pounds. He carried 1,010 pounds, 45 feet. And he lived through all those injuries. So I was trying to decide to myself, why does it work? Is it growth hormone? Is it IGF-1? Are we producing more myogenesis and revamping some of the satellite cells? And I looked at the axis myself, growth hormone from the brain, IGF-1 from the liver, secondary changes, and IGF-1 is certainly important in increasing muscle mass and lean body mass. But like I said before, in my generation, weightlifters tried to take the IGF-1 and it didn't do very much because it didn't last very long. And well, then I realized, well, you know what, there's IGF-1 binding protein in here. So maybe even though the IGF-1 levels aren't going up, maybe the binding proteins are pretty important, making them circulate. And so here's what I see normally now. When I look, this is an average male in his 50s, just looking at a baseline measurement and something 6 weeks later. You'll see the testosterone, both free and total, goes up. And more importantly, the CRPHS, which is a marker for inflammation and cardiac demise and stroke and heart disease, goes down. How many of your middle-aged patients that feel stronger and have better endurance are going to leave your practice when you tell them that their chances for heart and brain disease went down and they feel stronger at the same time? I think you got somebody who's going to play with you till the end. So this is a look at about 15 different patients. My buddy Jason standardized these down in Florida, and he looked just at these major biomarkers, and very importantly, CRPHS went down. Growth hormone moved a little bit for men and in the opposite direction for women, not significantly. The IGF-1 went down, and that's the reason that that's good. They were getting strong despite lower IGF-1 levels. And people with lower IGF-1 levels actually live longer. Interleukin-1 is bad. TGF-beta-1 is bad. TNF-alpha is bad. Those all went down. NT-proBNP, which is a strong predictor of cardiovascular risk and stroke, went down. SHBG, which is a predictor of diabetes as you get older, if it goes down, went up. And finally, testosterone, as we said, also went up. So a lot of these markers of senescence and aging were reversed even after 6 weeks. Cardiac. So this is interesting, and I want you to pay close attention. Even in the heart, there are progenitor cells. And the extracellular vesicles, which are the exosomes and the microvesicles, likely work together to secondarily change the behavior of those cells. One of the things that causes problems after myocardial infarction is oxidative stress and mitochondrial demise. And when they've injected rodents in their tail veins, peripheral circulation, with MSC exosomes, it improves. If you ligate the coronary artery initially, and then you inject them, it staves off the damage of the ischemia reperfusion injury so that the rodents don't have the same level of cardiomyopathy, they don't go on to heart failure, and they don't remodel the hearts the same way they would if they didn't have the exosomes. So if you ask me, because of the fact that these studies show that it works even if you ligate some of the arteries to your brain in these animals, and certainly we just showed you that it prevents the secondary changes of acute MI. If you came into my ER and you had a stroke or a heart attack, what's the first thing I'd give you? Exosomes. So this is pretty interesting. Somebody's working on a new drug. And the new drug is SR9009. That's not important. What's important is that in mice, it recapitulated the benefits that I just showed from exosomes. And what did it block? It blocked the NLRP3 inflammasome. Did anyone show you where else you can block the NLRP3 inflammasome? It's blocked in the discs by way of exosomes. So that's very, very important. I think that's one of the reasons that the exosomes are cardioprotective as well as protective. Now, diabetes mellitus, just so you know, GDF-15 prevents apoptosis of pancreatic cells. It also causes animals, if you have a fatty meal, you release a lot of GDF-15 so that you don't have the desire to keep eating the fats. But if I give you the GDF-15, you'll likely have better nutrition and you'll eat better. And by the way, I said earlier, when I give you metformin, I'm raising GDF-11, which is in the exosomes. So some of the ways that it helps diabetes, decreasing apoptosis. When you have less inflammation, proteins bind the receptors better. As your muscles grow and you grow more capillaries, you have less transit space from the cells and the vascular system into the cells themselves. So there's less area for insulin to get to. It doesn't have to walk as far. That's another reason why I think some of the diabetic profiles, the postprandial sugars, as well as the hemoglobin A1Cs, generally go down with exosomes. And in fact, many of the patients that are on diabetic drugs, specifically insulin, can decrease some of their insulin requirements by 50-60%. Liver. Well, liver fibrosis leads to cirrhosis, but what if you could fix that? So this is a real patient, 72 years old. She came in after one IV therapy. For those of you who aren't docs, SGPT and SGOT should be below 40. This normalized after one injection. This is almost normal. And the alk-phos is about, maybe 40-50% down. And the BUN, which is a marker of liver failure also, is rapidly going down. And even the creatinine improved. She's coming back in for a second injection, maybe along with an intraperitoneal. And there's been studies discussing liver fibrosis and what works. Renal failure, there actually is a nice study that uses exosomes from stem cells derived from cord blood. We're talking today about placental MSC exosomes, but even in these 40 patients, they increase the GFR and decrease the markers of renal disease, which are elevations of BUN and creatinine. This is a pretty interesting case. This is from a friend of mine in Ecuador. a general surgeon. So his 94-year-old grandma gets an infection, goes on to have chronic renal failure, hepatic failure, and they tell the family that they want to take her off life support because all of her levels are rising and she can't be helped. He gives her exosomes, and within 5 minutes she wakes up. Why? Because when you go into a situation, after you treat sepsis, what happens is that you get what's called a cytokine storm. That's what kills people. Even if you have the antibiotics on board, when your system starts doing this, it's the cytokines that are released by the bacteria that kills these patients. He fixed the cytokine storm, and within 3 weeks she got home and celebrated her 95th birthday. Peripheral nerve injury, there's layers of different nerve injuries, depending upon the severity. Neuromesis is certainly the most severe. One of the important aspects, peripheral nerves are a little bit easier to regenerate. There's a Schwann cell, which is a myelinating cell, in between every node of Ranvier, whereas in the central nervous system, the myelinating cells are called oligodendrocytes, and there's only one per exon. So the peripheral nervous system, the other thing that's very important, if you peripherally inject around the nerve, it's known as a perineural injection or a hydrodissection, and we frequently do these with ultrasound. The nerve, the Schwann cells, and the neuron will pick up the exosomes before these phagocytic cells, macrophages, can traffic them away. So that's one of the ways that we treat these. We also know that if you put it intrathecally, so here's a mouse model where they've ligated the nerve here, and if you put it in like you're doing a lumbar puncture on a pregnant woman, the exosomes will actually migrate not just to the dorsal root ganglion and the spinal cord, but they'll also go down the injured nerve root. So for those of you who have peripheral nerve injuries, you can catch it distally and you can catch it proximally and bathe the nerve in both directions. So I do a lot with neurological indications, and the reason this stuff works, bear in mind that when we use exosomes, we're kind of conducting a large orchestra. But we're really throwing the first few bars when we play the music. If we played the music and there were no violinists and there was no cellists and there was no one else playing, then the music would eventually die. So if you were bags that were empty without cells and I threw exosomes in, there would be a limited response and then everything would end. The reason it doesn't end is because specifically in the central nervous system, you can look at different cells. They pick up the exosomes, and then all of those cells start secreting their own exosomes and microvesicles, and the crescendo continues. And as I said before, not just the hippocampus, the hypothalamus, subventricular, subgranular areas of the brain, even into your ninth, and there's a more recent article I should substitute this for. In post-mortem studies, meaning after you die, they've sectioned people's brains, so in their ninth and even now their 10th decades of life, and they can find neurons, nerve cells, still turning over. We used to believe when I went to med school, once Christopher Reeves, always Christopher Reeves. Not true. So this is, I'm actually up to 98 intrathecal patients over the last 2 years. I've done, some of these patients have been cervical spine injections, some lumbar spine. If you look here at the pie chart, there's one or two more now. This shows you the first 96 patients. So I've dealt with a lot of these patients. I've had amazing results with spinal cord, strokes, Parkinson's, MS, and dementia. And then I've done a bunch of autism. Not all the autism patients I've treated. I've got 4 this way now. A lot of them I've just done IV and intranasal. Not all the parents want to have an intrathecal stick. But significant changes. Decreased echolalia, decreased self-stim, improved cognition, less outbursts, so it works for that too. I have Parkinson's patients that I've treated and had a walker within a few months. They're able to jog and catch footballs. I mean, really crazy stuff. And I'll show you some of the spinal cords that are never supposed to get better as we go on. So here's Chico. I texted Chico last week. He used to be the cheerleading coach of LSU. He had a great week last week. Anyway, 7 years ago, he has a horrific boating accident. So for those of you, again, who aren't doctors, The gray is the spinal cord, this is the base of your brain. The spinal cord is largely interrupted here. This is C3, so he's an Asia A C3-4. Asia A is essentially a complete cord transection. Now, you'll notice that there may be a little connection of the cord if we go out of plane, so that there is a little sliver. And what I like to tell people, you don't need the whole highway open. If you have a little connection, that's enough. So we do an injection, 8/23/18, and hopefully, can you click on these? There's two separate motors here, I don't want. So, oh, I didn't want that. Yeah, so if you click down here, there should be a start button, right? One here too. So what you notice, this is 3.5 weeks after injection. This kid's been living in a wheelchair for 7 years. And I've got a number of these kids right now, just like this. The other thing is, with a lot of spinal cord injuries, that they have an autonomic dysreflexia or orthostatic hypotension, that they have to take what are known as sympathomimetics, drugs that increase your sympathetic tone. Here he was taking Midodrine 3 times a day for 7 years. He takes it once in a while now. Again, these are more motions. You don't have to see all of them. You can click on the top left. You'll just see some hip flexors that were never firing before. And again, this is maybe 8 weeks after one injection. So some of these kids now I've done 2 or 3 times, but the rapidity of change is really remarkable. You know, if you injured your brain or your spinal cord, show of hands, how many people think that there's inflammation for weeks? How many think there's inflammation for months? Years? Decades? Decades. So they've looked at activated microglia, and one of the hypotheses between what's called neuropathic pain is that if you have a right brain injury, you'll find these activated glial cells on the contralateral hemisphere up to 2 decades later, and injuries to the spinal cord here, you'll find them in the spinal cord here and here up to decades later. Here's Sean. Some of these injuries are a little self-imposed. My friend Sean, he was in the Caribbean, and after a few cocktails, he thought it might be fun to jump from one of the rooms, the 3rd floor, to the other balcony. And Sean didn't make it. He gets a basilar skull fracture, and osmia, he can't smell anymore. And certainly he's got a horrible Asia A at T12. He's told he's never going to stand, he's never going to walk. I hear this all the time. So some of the sensory changes, you'll see that he's got some of the motor changes, he's got visceral changes, and he even got his smell back after we did some intranasals. So he's starting to walk here, and he's starting to do even better than that. Can you click on some of these? You'll see some hip flexion now that he's coming back. Remember, this is T12. Can you click these for me? And the second one as well. You'll see some hip stuff that they're not supposed to regain back. And again, this kid has had, at this point, 1 injection since I've given him the 2nd injection. Can you hit the second one? And a number of these kids now are starting to fire their hips. You'll see the first thing with spinal cords is they get their core back, and then they start getting really crazy changes. And he looks like 2 different kids. I think he put on about 15 pounds of muscle. On the one, he's using weights to stand him up, and this is, you'll look at it, he's holding on in order to walk. And if you go to the next post-injection treatments and click these on, now you'll see instead of getting assistance, I think he's got 30 or 40 pounds on the bar, and now he's standing, you'll see, on his own. And once you can lock your knees and move your hips, he'll be able to walk with assistance, for sure. I don't know if you hit the second one there. So part of the key is just getting up, getting your knees stabilized, and then being able to twist your hips and rotate your pelvis, and he'll be able to do that. So he worked very, very hard. I told a couple of guys that were out with me last night, my son actually plays this sport. The one on the left is an MRI, the one on the right is a CAT scan. They both show compressor fractures in C6, really horrendous injuries. Not football, not rugby, lacrosse. Both kids, listen, if you have kids playing these sports, both of these kids did this on the impact. As soon as I saw the second kid, I called every professional coach that I knew and athletes at the D1 and above level and told them about these two kids because I didn't normally see these type of injuries. So here's Jack. We injected him once at this point, and this is just a little, and you can click on this for me. This is a text message his mom sent me. He was able to stand before treatment. He had never walked without assistance before. And this is 3 months after one treatment. I use a lot of intranasal exosomes. One of the reasons is, and they compared in this animal study, this is actually mice with autism, and they looked at exosomes penetration and MSC penetration, and you'll notice that intranasally, exosomes was better than intravenously, but if you looked at exos getting into the brain comparing to stem cells, no comparison. And if you wash off the proteins in the exosome membranes, they also didn't get picked up as well. And the way they get there, this is transcytosis, where the exosomes are actually too big for the blood-brain barrier, but they get picked up by endothelial cells and pericytes and astrocytes. And they've done studies with status epilepticus in animals. They show intranasal routes where it's actually going through the cribriform plate. And I use a really expensive thing to do that. A 41-cent Afrin-looking bottle. So the intranasal protocols are exceedingly easy for those of you doctors that want a really simple way. And what it does, it gets to the hippocampus within 6 hours. It decreases inflammation, increases GABA cells, and decreases inflammatory cells. So I'll talk to you a lot about IV therapy, because I think that's kind of a take-home that everyone's here for. So aging and epigenetics. This is a nice split screen. It takes a minute. Can you guys run this for me? No? Can you run it or no? I forget it, don't worry about it. So occasionally it shows you, and it's from the Canadian Heart Association, and on the one side is an old guy barely getting in bed and putting out his oxygen, the other guy's playing tennis with his kids, and it just shows the parallels between living at your years and living healthfully at your years. So, can we fix clinical immortality? And the idea of clinical immortality has been out there for some time now. So, I have talked about the fact that, after you're in your 20s and 30s, you start catabolizing and there's less anabolism. But also very importantly, you get these senescent cells. For years, we thought that Parkinson's was cell death and your dopamine neurons die, and there's no way to fix that. Now we know that even in Parkinson's disease, they've actually stained the neurons. Cells fall asleep and don't do anything before they die. So it's true in the brain, it's true elsewhere. And when you look at senescent cells, we used to think this was irreversible. A senescent cell, we all know that if our cells divide endlessly, eventually they'll undergo mitoses to the extent that they'll get teratomas and cancers. So your cells shut down division for a while. The problem is, while they stop dividing, they don't turn into cancer, but there's something known as an innocent bystander effect. So while this cell stops dividing, it causes the secretion of a senescent-associated secretory phenotype, where it's anti-growth and pro-inflammatory. So all the cells in the vicinity, they get bathed in this stuff and they go sideways. So the senescent cells and premature senescence is one of the major problems we have. Redox homeostasis is basically looking at oxidative stress and free radicals. We need to reduce that. And we certainly need to reboot the mitochondria. And we need to reduce inflammation. So we've all been looking for the fountain of youth. GDF11 is short-lived protein. Certainly there is GDF11 messenger RNA in the exosomes. So by show of hands, how many of you guys think that you're screwed based on your genetics? I've seen this a lot. It should interest you that the people who live in the blue zones, and Loma Linda, California, and Costa Rica, and Okinawa, Japan, they are not genetically so distinct from the people that live outside their blue zones. But Mediterranean diet, intermittent fasting, no drinking, no smoking. So epigenetically, what they do to their DNA is markedly more important to the DNA itself. And in fact, 7% of your longevity is based on your DNA. Yeah, there are some outliers that are just bad protoplasm, they're screwed. That is not the majority of you. So as we age, all the things that, this is going to make people sad, but loss of bone and cartilage and muscle mass and strength, and we get thick in the midline. Hormone levels go in the wrong direction, as does blood pressure and lipids. We get insulin resistance, and our vessels become more stiff. So we're fighting a losing battle, because even if you do the intermittent fasting and a physical activity, and you take your 5,000 units of vitamin D, and you do your cognitive training, and you take your metformin or your rapamycin, incomplete benefit and poorly tolerated by everybody. So here's the hallmarks of aging, and we're not going to tackle one at a time. We're going to try to attack them all together. So the genome becoming unstable, the telomere attrition, we talked about that, the alterations in your epigenetics, the loss of normal protein function, deregulated nutrient sensing, similar to insulin and NAD, mitochondrial demise, cellular senescence, which we touched on. We talked earlier about stem cell exhaustion, right? Your stem cells get less plentiful, but they also get less vibrant. And finally, there's some poor intercellular communication. So if we're going to make you live longer and better, we need an answer that will attack all of these things, not just some of them. So, vampires, I like to say, are the ultimate biohackers. Because if you believe in young blood, they've got it right. So they suck young blood and they live forever. So it makes sense, right? So here's the deal. When we look at epigenetics, that's what we can do to our own DNA. Maybe this ear thing will fix eventually. When you look at your own DNA, things you can do. You can put histone proteins on it. That wraps it up. You could put methyl groups. And the last one is something that is imprinting. Sometimes mom has some DNA that's wrapped up and dad doesn't. So the gene that you get is strictly from your father because that's what's been imprinted on you. So that's a little bit more quasi for you. You don't need to worry about that. But you should worry about methylation and histone modification. So I'm going to remind you back from your basic biology. I don't know if this is 7th or 8th grade. DNA transcribes into RNA. RNA translates into proteins. Transcription is hard. Translation is easy. And the more open your DNA is, more like euchromatin, the more DNA gets turned into RNA and turned into protein. The more wrapped up it is, like heterochromatin, the less DNA turns into RNA and turns into proteins. So I said earlier, this can be done secondarily by changing the inflammatory milieu and changing the oxidative stress, or this can be done directly by the release of histone acetyltransferases that directly unravel your DNA. Epigenetics. So if you look at cancers and aging and heart disease and lung disease and liver disease and brain disease, 10 or 15% is based on your genetics. So what did I just tell you today? Your longevity, 7%, chronic illness, 10 or 15%. Sound like a broken record, right? So the epigenetics can be affected by your internal environment, the cellular messaging, the oxidative stress at the cellular level, external environment, radiation, chemicals, the smoking and the drinking, and the general external environment. The stress I have from renting from this guy who's just breaking my horns every time I come home from work. Right? So all of these things affect you. So sometimes I lecture and people don't believe me. So I find that's a little instructive when I share a little bit of an anecdote. So this is a PhD postdoctoral fellow, Brian Diaz, and he gets a really bright idea. He's going to take mice, and he's going to put them in little boxes, and he's going to put acetophenone, which is a cherry vanilla smell, right across the box. And then as soon as the little mice smell it, he's going to zap them and shock them. And he does this for a series of days. It's a sick mofo. So he does this to these mice, and then after about a week of torturing these pure little animals, he takes them and he mates them. And then he takes their progeny. So these are the children of the shocked acetophenone mice. And he takes them and puts them in a box. And he puts the acetophenone, he wafts it just across the top of the box, and they jump without being shocked. Yeah, that's crazy. So then he takes the children, pulls them out of the box, and he mates them. So now they have babies. So these are the grandchildren of the ones that he shocked originally. Puts them in a box, wafts across the acetophenone. They startle reflex. This is transgenerational inheritance of epigenetic changes. And what happens is that essentially the olfactory code of the olfactory 151 gene is somehow upregulated and brought into the progeny, into the sperm. And what happens is, in the new babies, they've got like this bigger olfactory gene, so they have a hyperreaction to the smell, where it causes a startle reaction too. And people say, well, that doesn't happen in people, right? Well, if you have maternal stress, those babies have problems. And if you were the children or grandchildren of Holocaust survivors, you've got an increased risk of depression, PTSD, and even anxiety. So it does happen. So this is some of the form of soft inheritance that we didn't really believe happened, but it does happen. In the next few years, we're going to have more people 65 and over than we will younger than 5 years old. And what that means, we're going to have associated with it all the problems of aging. So many of us in that room are going to fall into that. And what we want to do is we want to push that red graph towards the green. We want to have a longer life, but we want to have more of a health span and not just a lifespan. When I look at the exosomes and I look at the benefits that you'll see protein benefits, days, hours, right? We saw the protein benefits on the Cytokine Storm and that 94-year-old lady earlier today. You're going to see mRNA changes. Those are weeks and months, and you saw those with Chico and some of those other spinal cord injuries. I haven't yet shown you the epigenetic changes. I'm going to wait and hold those for you in a little while. Oxidative stress. So, who does intermittent fasting? I wrestled through college. I really don't like doing it, but sometimes I'm too busy in the morning, so I just have my coffee. And by the way, I love my coffee. But as much coffee as you drink, you should probably drink as much water. So, I'm oscillating today. That's kind of what I do when I lecture. So, when you burn wood, what happens? Come on, this ain't first grade. When you burn wood, what happens? You get heat. And what else do you get? Smoke. Good. We're doing good. If I put sugar in my body, I make ATP. That's energy. I make that from the mitochondria. But when the mitochondria make ATP, they also release free radicals. Reactive oxygen species, reactive nitrogen species that hammer your lipids and your carbohydrates and your protein and even your DNA. Right? So as they make the energy, so too they give off the smoke. As we get older, we have less of the antioxidants to combat the mitochondrial stress and the reactive oxygen and nitrogen species. So one of the things you do if you don't eat in the morning, you really didn't need those calories and you didn't need to stress the hell out of the mitochondria. You can just let them sleep that morning. You got enough energy on board already. That's one of the reasons that people fast. So the reactive oxygen and nitrogen species are a byproduct of you making fuel, ATP. And that's one of the problems. We used to think inflammation. Now we think oxidative stress inflammation. So oxidative stress causes these reactive oxygen and nitrogen species. The cells go sideways. They start producing senescent cells. The senescent cells spit out all the inflammatory mediators. Now you start aging from all of those different factors, both separately and together. So if you look at oxidative stress, there have been studies linking it to cardiovascular disease, COPD, kidney disease, brain disease, cancer, sarcopenia, frailty. And again, there's endogenous sources of these problems, And there's exogenous sources. You can only really fix the exogenous sources, although I know some of you are taking NAD and glutathione and everything else. There are also endogenous and exogenous things you can do to help. The enzymes, superoxide dismutase and catalase are very important, and you can also take vitamin C and vitamin E and resveratrol and things like that. So we've talked a little bit, the senescence, the senescent-associated secretory phenotypes, the inflammatory cytokines. Does everybody see this is all the same? As we age, all of these things are happening together. So there's been studies, oxidative stress and cardiovascular disease, diabetes, COPD, chronic kidney disease, cognitive impairment and dementia, ALS. And by the way, we talk about ALS, the sporadic form is 95%, but the familial form, that 5% has decreased superoxide dismutase, which leads to more oxidative stress, more inflammation, and more down clumping of TDP-43, which is a protein that shouldn't be there. Cancer is associated with oxidative stress, sarcopenia, lack of motor function. And again, we can check some of these biomarkers. And there's been a study. Today, by the way, I'm talking about placental MSC exosomes from chimera. There's been a study where H2O2, which is hydrogen peroxide, induces oxidative stress, and when they added placental extracellular vesicles from MSCs, they rebooted the normal milieu and fought the oxidative stress. So I'm not pitching to you just from my own mind. There are both animal studies and Petri studies that show some of this stuff. One of the big knockout models of mice, I don't know if you know what a knockout is. If you take, and this is above the clinicians' purvey, this is basically scientists can turn off some of the genes in some of the animals. So if you turn off the gene that produces interleukin 10, interleukin 10 is a profound anti-inflammatory agent. If you turn off the interleukin 10 in these mice, they get inflammatory bowel disease. So the equivalent of ulcerative colitis and Crohn's disease. And when they were given MSCs, they decreased all of their free radical oxygen. They had less hydrogen peroxide production, and they produced less methylaldehyde. Similarly, they increased the amount of catalase, which breaks down the oxidative markers, and they increased the amount of the superoxide dismutases. And we've talked so much about the mitochondria. So longevity. I noticed that as I walked in today, Barry had his own Fountain of Youth. This is actually myself and Duncan Ross at the Fountain of Youth in St. Augustine. And people are still trying to drink this water. It really skeeves me, but people are trying to get young drinking it. So some of the biomarkers I used, I will admit that in the last few months, I've kind of gotten rid of some of the ADMA, SDMA, lipoprotein PLA2, and myeloperoxidase, and I've adopted some of the other markers that was on that chart earlier. But I do like to get the total free testosterone and SHBG. For women, I like to test for CA125 pelvic malignancies. For men, I check PSA. There's a marker of oxidative stress. It's a blood test we get in the US for about $179 that looks at all of the precursors. And then I've started doing my DNH test. This is a test of methylation of your DNA. So you can give people a treatment. And again, the exosomes are the mainstay of my longevity panel. You can certainly give people hyperbaric oxygen and give them, some people like the infrared sauna, and you can add pre and probiotics. This is one step, and I think it's the nicest step because it's very easy. I tell people to come in for a longevity lunch. We put in Heplock, we infuse you over 5 minutes, and you can go play. And that's just how I take mine. These are some of the markers we look for inflammation. Obviously, if you've got Hashimoto's thyroiditis, or you have other markers other just ANA and CRPHS, you can take those at baseline and take those at 6 or 12 weeks. And these are essentially the panels that we use for the oxidative stress. This is the DNH test. The DNH test will show you your chronological age as well as your biological age. Here's a patient It's accurate to about 1.7, 1.8 years. Here's a patient. He's 95, he's really old. It showed he was 112. 3 months later, he was still 95, but he went down to 110. Statistically significant. I don't have enough of these to show you. It's one of the things you can look at. You can also look at heart rate variability. The more variability in your heart rate, the healthier your heart is. And we know that there's NLRP3 inflammasome blockage. So I think if you're not going to do anything else, this is a great way for you to manage heart disease. And there are some things you can do at home. You can buy some of these heart rate monitors. This one runs about $500. So for those of you any biohackers here? I know I got some biohackers. You guys want to stay young forever? You just came here to hang out with me today. You're all biohackers, yeah. So these are things you can do for yourself if you want to monitor your treatment. Your heart rate variability will improve with exercise. They did a study on mice. There's problems now with people taking just plain NAD because it says one of the things the NAD does, it also keeps the senescent cells around. Well, they found in mice that ENAMPT also keeps you in longevity, and this is found only in the extracellular vesicles, so maybe you don't even have to take the NAD. This is, anyone ever see Benjamin Button? So Benjamin Button is it's a really heart-wrenching saga where this kid ages backwards, and the older he gets, the younger he gets. Sadly, there are children who age prematurely. It's the Hutchinson-Gilford progeria syndrome. And what they have is they have rapid senescence. Well, they actually did a study with senescent cells in mice, and not just induced pluripotent stem cells, which are kind of embryonic cells causing EVs and extracellular vesicles and exosomes, but even the extracellular vesicles from neonatal tissues were able to fix the progeric cells. So it may be possible to offset some of the disease of progeria and give these kids some years back. I've been trying earnestly to find one that will come into my clinic. I haven't seen one yet. The butterfly effect. I like to pull in films because this is a really nice one. And when you look at the butterfly effect, and this is Ashton Kutcher, what happens is you realize after watching this show that small changes can permanently change and markedly change the trajectory of your life. And for those of you who came here today and are learning about Chimera's exosomes, I think you'll realize that just the act of getting intravenous exosomes may make a marked change on both your longevity and your healthful years going forward. The reason I say this is a kid I almost did not treat. This is a kid from the Cleveland Clinic, and I don't know how it is down here, but there are some areas of excellence in the United States where certain clinics think that they're just smarter, and those doctors are smarter than the rest of us. And often, when you're trying to get pre-certification that you need a medical clearance to put a kid on the table, you've got to call one of these doctors and entertain the browbeating that will be brought down upon you for telling them that you're going to do something way different than they believe in, that the kid who's been told that he's an Asia A or a complete spinal cord injury from an ATV a year and a half again with 0 out of 5, I'll tell you that is 0 motor function, is never going to stand or walk, and that you're a heretic, a liar, and a cheat, and how dare you take money from him and his parents. And if you look at his spinal cord, of course I'm the radiologist, she's not, and I did look at the spinal cord. I said, well, you know, it looks like there may be a little tether of cord still connected. It doesn't look like it's totally interrupted. Oh, that's non sequitur, it doesn't matter. It's fluid replaced, myeloablation changes, and all of that. I said, just humor me. The parents want to do it, the kid wants to do it, let me treat the kid. So she acquiesces, and I want you to hit these, because this is remarkable. I talked a lot about epigenetics, and you can click on these for me, but the importance of this fact is that some of these people don't demonstrate change for 4, 5, or 6 months. Can you start these, please? And what happens is that some of these people you think will have very moderate changes. This kid doesn't start crawling for 5 months. After that, he gets hip flexion, and then he starts standing. And this is after 1 treatment. So I've since treated him the second time, this kid is going to walk. The extent of which he'll need help is not up to me, up to him. I tell everybody I'm a really good plumber, but what I put in is not up to me. So you're seeing changes in kids that were told that they would never have these changes. So with respect to the epigenetics, there's a lot of things that you can modulate. And the benefit of you modulating the amount of drinking and smoking and other stuff that you're doing is limited, and it's frequently limited by how much you'll adopt. Right? Who eats red meat here? Even occasionally. Right? Now we all know that red meat is not compatible with longevity, right? Don't you love a steak once in a while? Right, so I would be a liar if I was telling you I didn't have a steak once in a while. I've decreased the amount of steak, and I'm watching my cholesterol, and some of you may be on statins, but it's not fair for me to tell you I want you to live in a box. I don't want you to be around alcohol or meat, and if you don't eat the Mediterranean diet, you're all going to die next week. You don't want to hear that from me. I'm trying to help you live better with what you have. Whatever else you do on top of that is up to all of you. So for the docs, I can supply you with the dosing regimens and the protocols. So I have protocols for this stuff: ED, erectile dysfunction, for the clitoral injections and urinary incontinence and hair, musculoskeletal packages, discs, neuropathy, CNS disease, longevity, performance, and all these other things via IV. Lyme we talked a little bit about. This is for interstitial fibrosis and COPD. We can talk about wounds and how to treat them. Some dosing by weight. There's 20 mLs is 20 billion units, 5 mLs is 5 billion. What to do for people that have concurrent viral and bacterial infections. So some of the contraindications, let's talk a little bit about these. I call these relative contraindications. What does it mean? It means if you had a brain injury and you got a basal cell carcinoma, who thinks I'm going to treat that patient? Oh, I'm going to treat him every day, twice this Tuesday. Suppose you got a melanoma and you want me to do your epicondylitis and your golfer's elbow. I may stand clear. Now, we know that there are proteins and mRNA in the exosomes that are anti-tumor. There's P53. By the way, P53 and P10 are some of the things that are lacking in prostate, in pancreatic cancers. So maybe if you give those people will do better. I do have a patient with a neuroendocrine tumor that was supposed to die 15 months ago. He was told that he had 2 or 3 months. We gave him IV because they weren't giving him anything except a death certificate. And I gave him intraperitoneal. His tumor stopped growing 15 months ago and hasn't come back. Anecdotal, true. Doesn't mean that I'm advocating the treatment of every cancer. I'm just telling you that there are some benefits, and even in vitro studies and animal studies showing decreases in some of these cells in the petri dish. Certain breast cancers, certain glial tumors, colon cancers, and the like. Myeloproliferative disease, I don't know what it's going to do to a sickle cell. So if I'm not treating you for a brain injury with sickle cell or a major myeloproliferative disease, I probably won't treat you. Primary pulmonary hypertension, this is too many pulmonary artery cells. This is not just high blood pressure. If you have acute bacterial infection, I'm going to take care of the infection. Macular degeneration, the one that I worry about is wet type. There are anti-VEGF drugs now on the market. So if you have wet macular degeneration, this is a relative contraindication. If you have a spinal cord injury and wet macular degeneration, we're going to probably treat you, and we're going to get on the phone with the ophthalmologist and say, you may need to laser this patient a little bit more regularly. And that's true with other neovascularizations. Immunocompromised. If you have HIV, I will not treat you. Not worth my risk. If you have HIV, you just had a brain injury, and you're near death, I'll roll the dice with you. All right, that's pretty much what I wanted to share with you. I told you I'd go quick after the break. I know we lost a couple of you. If you want to have questions for me, I'll give you my email. My email is body, B-O-D-Y, doc, 06 at yahoo.com. Bodydoc06 at yahoo.com. Give me some time to get back to your questions if you have them. I try to answer all my emails. And other than that, Barry, I don't know if he's here. Yeah, if we got a couple of questions, I think we got plenty of time. Do we have some questions? It's certainly fair game to field them in front of everyone. Yes, sir. So some of the advantages are pretty plain. Right now, the company is pursuing 2 or 3 different INDs in the U.S. Those INDs, I'll put everything that we're currently working on. So some of the INDs include craniofacial neuralgia, atypical facial pain, facial aesthetics, and then we're considering doing one for spinal cord injuries. There will continue to be a market outside the U.S., regardless of what the market looks like in the U.S. Both, we have quality assurance and everything else that's certainly there. For ease of use, I don't know that it pays for you to travel back to get IVs and some of these easier injections. There are plenty of good skilled doctors here that I've either trained or will train in order to do many of the procedures out here. And again, I'm one guy in New Jersey. So just as I train doctors in the U.S., I'll train doctors here. And Barry's been good enough to set me up with some of the docs, and we'll have some more workshops for them so that I can teach them some of the safeguards that I use in doing these cases. And again, there are anesthesiologists in the US, there's anesthesiologists here, I was a radiologist, and the idea for me to teach doctors, the benefits of the medicine is inherent in the medicine. I just have to teach people how to use it safely. And the skill sets necessary to do 90% of what I do is available to everyone. You know, are there some things that I may do better? Yes. I've been doing certain forms of medicine for 20 odd years. But there are pain docs here that take the same international exams that I take. So theoretically, if they want to learn, I can teach them. And for the most part, the vast majority of these procedures, and I tell docs, even in the US on a 1-day or 2-day course, I said, you'll leave my course, and by Monday, you'll be able to do all 80% of the cases I teach you. So that's not so different. Some of the regulatory environment may be different. Good question. Yes? So I don't use any stem cells. These are, so how we do it at Chimera, loosely, and Duncan Ross is much more articulate than me. He takes a placenta, and by the way, scientists don't like stage 1, because it's a bloody mess, it looks like a murder like it does like we do fusion surgeries in the OR. So you've got to grate up the placenta and take out all the placental stem cells, the mesenchymal stem cells. Once you're through with the bloody side, then you got to plate them, and when you plate them, you grow them to a certain level of confluence. That's proprietary, how many doublings we get to get there. You don't keep doubling them year after year, that's not the way it's played. You get to a certain level of confluence, and there's a proprietary way where we replace the food, and then spin off cells and food from secretions, and then we rebottle the secretions in saline. That's a proprietary process. The reason it's proprietary, if you patent every step in that process, everybody can knock you off. Because each step is not novel. The series of steps is novel. So yes, we use placental MSC exosomes because we find them to be the most pro-growth and anti-inflammatory. Those are the 2 sentinel aspects that are different than all the other things out there. Growth, anti-inflammation. And then we've talked about reducing oxidative stress and all those things working together. Yes, the girl first, okay? The young girl. The pretty young girl. Go on, that's it? All right.
I'm not understanding what you're saying. It sounds like hopes and dreams.
Yes, okay. So if you look at autism, there's a multifactorial cause of autism. You can look at PCVs, you can look at maternal antibodies, you can look at abnormal arborization of nerves. There's a number of things. probably some kids get a vaccine and they get a super antigen reaction from it. Everybody that gets to autism spectrum disorder does not come to it from the same pathway. What is generically similar in all of them is a brain on fire or an inflammatory brain. The two ways to treat that are peripheral inflammation and central inflammation. The treatments that are out there that work, and you can read the papers, you can take stool from people with more gut diversity. People with autism have diminished gut diversity. They produce less brands of bacteria than even their age-matched siblings. You give them more diversity that improves the bowel and decreases inflammation, and there's studies where after they've treated them, 70-80% of the kids that have autism spectrum disorder don't even meet criteria after a few months of giving them fecal transplantation. The other ways to decrease inflammation is here, IV, intranasally, and intrathecally. You could go further, right? I say that this is, when you start understanding medicine, one of the ways we treat PTSD is stellate ganglion blocks, which blocks the sympathetic nervous system. If you remember, you have a sympathetic and a parasympathetic. Sympathetic is inflammatory, parasympathetic is anti-inflammatory. One of the other ways that decreases inflammation, vagal nerve stimulation. With all of the kids I've seen over the last couple of years with autism, decreasing inflammation changes the behaviors. When I look at decreasing inflammation, I'm left with 3 ways that I can get it in children without going intraperitoneally. The reason I don't do more IP with these young kids is they won't sit still. And most of the kids with, actually I did an autism, not true. I did an autism last week where I did a cervical injection in the cisterna magna in a 19-year-old. But he was already highly functional. And he sat, and Dad was mad that I didn't wait for him, he's a doctor, to come in the OR. But the kid was on the table doing well. I didn't want to freak the kid out. He'd already been taped in position. I had my fluoro machine. They were giving him hell for not having all his vaccines. I put him on the table and we went. All of these kids that I've seen, and here's another example. So decrease echolalia, decrease self-stim, improve cognition, decrease outbursts. One of the kids used to come in and eat 30 Slim Jims. So Slim Jims are these little tubes of beef that come in a package, and this kid was eating 30 of them. Probably due to an inflammation in the satiety center of his brain in an area of the thalamus. It's a ventromedial thalamus, you can look it up. After the treatment, he'll eat 1 or 2 and walk out. So maybe it's due to the GDF-15, maybe it's due to the anti-inflammation in the thalamus, but for one reason or another, the satiety center was fixed. And some of these kids become more vocal too. So I've seen a large amount of changes. At some point, I've done 10 or 12 autisms. Some of the kids get IV and intranasal, a couple have had intrathecal, maybe 4 or 5, but it's getting to the point now where it's no longer anecdotal. I've done enough, and it's statistically significant that I shouldn't have that many kids getting better if there wasn't a reason for it. Right? I have done more than 3 dozen spinal cords. It's no longer anecdotal, because no one has the results that I've had with spinal cords. No one's got the number yet. I don't advertise for them, but the spinal cord kids, they're on social media all the time. The brain injuries and the Parkinson's, they don't do the social media stuff. Good-looking young gentleman, and then the pretty girl. Sorry.
You talked primarily of delivery via IV. What are your thoughts of areas of variability? For example,
Like where?
around like centuries and centuries.
So I do direct injections, musculoskeletal. So,
Do you have any sort of like scaffolding to keep that?
yes. So excellent question. The question is, when do I use a scaffold? And they've actually done studies with rabbit joints, where if you just put exosomes in, or if you put them with a scaffold, hyaluronic acid, PRP or PRFM, that with the scaffold holds them there longer and they do better. So when I'm going into a joint or richly vascularized area, then I use platelet-rich fiber matrix. We can use PRP. We can even use hyaluronic acid in some of these areas.
How expensive is the procedures?
I'm sorry?
How expensive are the procedures?
So I guess Barry and his docs will talk to you about specific ones, because there's obviously a wide range. So intrathecal, intradiscal, where we're going to put you on a table somewhere, is far more expensive than just doing it intravenous. Oh, yeah?
Can you talk a little bit about Parkinson's? Did I understand you've only treated 6 patients?
I think I've about 6 or 7 Parkinson's, yeah.
And are any of them off the medication or?
Nobody's off. No. I haven't seen anybody off. I've seen people drop their dose 50, 60% with less tremors and with significantly improved motion. Some people are climbing upstairs and into barber's chairs that they couldn't do before. I've got other people that can walk without walkers and able to jog. I've got other people that can stand erect and no longer have as much as the pill rolling tremors. And again, this is a disease entity where it only gets worse. So when I see somebody a year out that's not only not worse but better, that's statistically significant, even with, it's ridiculously significant.
Have you seen like in a CT scan changes in brain or have you done?
Haven't done it. So what I'm doing right now, I'm starting to work with a group out of New York that does functional MRIs and the like, because I'm a clinician, I'm a standalone guy. So as you know, a clinical doc, it's hard for me to run all of these studies. I have 0 research assistants. So I do interventional pain and I do regenerative medicine in Jersey. And I try to keep tabs and do follow-ups on people, but it's not the same as putting people through the queue and getting a functional MR before or DTI of the brain and the spinal cord before and after. That's what I'm pushing to do going forward.
You mentioned using this technology for the last 15 months on yourself to treat your asthma. What are the long-term dosing regimens you're talking about? Or are you ever expecting to...
Will I ever not need it? No, I think I probably will, because I still age. So the question is, you know, I'm giving myself, I probably am epigenetically changing myself to some degree, but I'm not giving myself new DNA. So I'm not causing like a chimer. Like many of you may have read recently, the one guy ablated his bone marrow and had a bone marrow transfer. And when he looked at the DNA of some of the cells, they were chimers, so that he had some of his own original DNA and some of the DNA of the bone marrow transplant. I'm not chimerization, so I'm not giving myself new DNA. I probably unwrap some of my DNA, and then I'm changing the inflammatory milieu significantly for 12 months, but then it goes down from there.
Can you touch on the brain treatments using MS?
So I have a handful of MS, both primary progressive and secondary progressive. As you know, MS is funny. So MS is, there's 2 aspects to MS. When you look at the MRI changes with Gatto, you're primarily looking at the white matter changes, but there are also gray matter changes even with MS. And one of the aspects that originally made it hard in our minds was that we thought all of the oligodendrocytes were dead. Some of the studies now suggest that some of the oligos are either senescent or just kind of weakened. So they may still be present. So with MS, I've seen people, some of their progression shut down. And again, I've become agnostic to what the brain or spinal cord injury is. The one big problem I've had has been ALS. And I think part of the reason I've had such a big problem with ALS, I don't think I'm giving enough and enough frequently. So I've seen some of the fasciculations go away for a little while, but I think ALS is such a rapidly progressive disease that the inflammatory milieu in the CNS probably would require us to put like an Ommaya shunt in or put a catheter and keep infusing. So I've been reticent to say that I've really healed a lot of these ALS patients. Duncan said a couple of years ago he had some slowly progressive ones that stayed without moving forward for a number of months. And I think that's possible if you get people early. Not everybody is radically progressive. Some people are a little bit slower than others. But for everybody else, whether it's brain injury or spinal cord injury or neurodegenerative disease, once you have death, you have inflammation. And fixing the inflammation is the first part to kind of getting them to function better. And I think that's the big thing that we do really well, is shut down the inflammation. How many of the neural stem cells and glial cells will start working after that, I can't tell you on a microscopic level.
You're doing the harvesting, but I don't understand.
I don't do any harvesting.
Well, where
Camaro.
how do they guarantee that they're not harvesting something that's got a disease?
Right, so if you take umbilical cord or Wharton's jelly, how many aliquots do you think you get from that one cord? 20? 30? When we do a placenta, we can get 10,000 plus units per placenta. We can afford to do HIV, HTLV, Zika testing, and other testing that other people can't do because it's spread out. Even if it's $7,000 for a Zika test, what is that, $1 a unit? Not even $1 a unit. So we can afford to test for more than others test for. Plus, if you get beyond that, the placenta is not really a nidus for hiding infections, but that's all separate. We still do the virology testing, the bacteriology testing, and there's no DNA. That's even more important. DNA is found in larger exosomes from cancer where there's 600 and 800 nanometers, not below 200, 220 nanometers. Barry, you want to come up and say a few things?
You want me to, okay, I can speak from here. Okay, well, you're finishing now? Yes?
Yeah.
Okay. Well, thank you very much for coming, and it was a very informative discussion. We're having another seminar tonight at 7 o'clock, and it's also the opening of our clinic down below. As you can see, it's not quite ready. It will be ready in about 2 weeks. But what we're suggesting to people, if they would like to have a consultation, we have, I think, 9 doctors here. You can have a consultation with them, talk about the exosomes and the stem cells, which we use in combination. And if you make a consultation, it's a free consultation, between now and the 1st of February, we will give you, at no charge, a Myers cocktail, if you know what the Myers cocktail is, and also you can get one of our stem cell nutrient booster implants, which goes here, and it's normally $500, we do it for $250, but you need to make a consultation with one of the doctors here. They'll be here today, right now, or you can contact the girls and make a consultation, a free consultation for the next 2 weeks. The procedures will be done at our existing location, which is at kilometre 30, and we won't be doing procedures here for about another 2 weeks because we have quite a lot of work down below that needs to be completed. Anyway, I'd like to thank you very much for coming, and also for Dr. Spiel making a trip down here to see us. He's leaving tomorrow, so if you have any questions at all, you can speak to him after this event, or any of the doctors that are here. You can talk to them and get more information. Thank you very much for coming.